Welcome back to Medical Monday. I'm here with Dr. Jan Brandis, a neurologist here in town, and you were telling me neurologists are harder and harder to come by when it comes to that headache specialty. This isn't something that people are seeking out much anymore, it sounds like.
No, interestingly, we have, I think there are now 21 headache fellowships across the country, and last year, the last number I heard was that 7 filled.
Just
so
7.
Most of the headache care in the United States is really provided in primary care settings. So it's always fun to be able to work with medical students and to work with primary care residents to really talk about this, because they are the ones who will see the vast majority of headaches, and pediatricians in particular, because if you can identify the migraine patient early and we believe treat acutely and then watch their hormonal influences and then make sure they're treating with acute medicine that stops the attack quickly, you hope that you can prevent that escalation that I think Pam was talking about, where you go from childhood headache into chronic daily or at least over 15. And migraine's actually more common in boys than in girls until girls begin having their menstrual cycles.
Because of hormones.
Because of
we
hormones.
love those hormones. I want to ask you about that. I told you I have a 4-year-old and a 2-year-old, and they've never complained about headaches. I wonder if they don't know what it is or don't know how to verbalize it. But when do children really start having headaches? Do we know generally?
Well, some children have what we would call childhood equivalents of migraine even as young as your 2 little ones. So there is a paroxysmal or sudden vestibular change, so they may hold on to the crib. That's how it was first described in a sibling pair. They would hold on to the crib. You could see their little eyes going back and forth. They would hold on because they were having this episode of dizziness. They would vomit and of course cry, and then it would last for a few minutes, and then they would lie down, sleep. When they woke up, they'd be fine. So that's, you know, they're too young to really say I have a headache, but those are viewed as childhood equivalents of migraine. So it's a benign paroxysmal pattern of dizziness that is a vestibular pattern. That's really how children present. Some children have abdominal migraine, where again they don't complain of headache, but they have cyclic patterns of nausea and vomiting. And sometimes they get huge gastrointestinal workups, and then they run across a GI specialist that goes,
wait a second,
maybe this is migraine.
Really?
And again, that's so it's really, pediatricians are really, and family practitioners who take care of children, they're often the first line for migraine. So it can start in, you know, virtually from infancy to toddler years, but many children will, I'd say of my adult patients like Pam, I would say of the ones who have chronic migraine more than 15 days a month, I would say more than half of them began having headache in childhood.
And that's terrible, because sometimes the parents are like, come on, you're fine, just let's go. When do you know it's more than that? You need to take it seriously.
Oh, I think mother's intuition probably plays a really strong role in that. It's really interesting to me, though. I'd say that most of the time, mothers are more likely to be, or fathers are more likely to be dismissive if they have migraine, because they're often afraid that their child is mimicking them. They've heard them or seen them, when in reality, that child's got about, if they've got one parent with migraine, they have a 50% chance of getting it. If they have 2, they have a 75% chance.
Wow.
So they really need to be paying close attention. But I would say that in general, if a child can, you know, you make sure they're hydrated. If they can lie down and take a little nap and the headache goes away, that shuts down firing in the dorsal raphe nucleus. So that's really helpful during migraine. That's a very common way to treat it, because pediatric migraine is typically much shorter than in adults. So if they do that, that's, I think, a great way to do it. But when you notice they don't want to go outside to play, they don't want to go to school, they are missing athletic activities, or they're just missing things that are to them are fun. I think that's a time to talk about it with their pediatrician or their family practitioner.
I want to let everyone at home know our lines are open right now, so if you have a question, go ahead and give us a call. We can get you right in. 615-737+ is the number if you have a question about headaches, about migraines. Now is the time to call. You mentioned that boys tend to have more headaches until that hormonal stage, when girls take over a bit. Let's talk about the hormonal effect on headaches and migraines from, you know, when you start your menstrual cycle to premenopause.
Well, once girls start having their menstrual cycles, their numbers go higher than boys in terms of migraine, and they stay up for the rest of their lives, although the numbers do come down after menopause, after natural menopause, in about 45% of women. So when women have ovulation and the estrogen bump goes up then down, then the higher rise in estrogen and the bigger fall in estrogen triggering the menstrual cycle, that fluctuation in estrogen is felt to change the excitability of the neuronal membrane, and that, if you have one of the genes for migraine, can give you that susceptibility to attack. So many women have ovulatory migraine and they have menstrual migraine, and that can occur at any point. So some women have it 2 days before the first day of their menstrual flow. Other women have it the day of the menstrual flow. Some women have it after the estrogen's going back up. So it may be different with different periods. That's where a diary is so helpful.
And I'd imagine then if you can kind of track, okay, I usually get it 2 days before my period or 2 days before I ovulate, then with preventative medicines you can say, okay, I need to be taking this now. Is that fair?
That's exactly right. That's not only fair, but that's exactly the way to do it. And if you can identify it, say, in an adolescent who's just started that pattern, you may be able to use a single dose that will stop it if it's a one-day attack. The other thing you can do is to use something called short-term menstrual migraine prevention, which is where you take a long-acting migraine-specific medication like a triptan, naratriptan, and frovatriptan are two that have been formally studied in clinical trials for this. And then you start it before that drop, so you try to keep it, and they may take it for 4 to 6 days just then to see if you can prevent that attack. So exactly what you're talking about. So it may be a single dose or maybe another one. So those are times when girls are vulnerable. And then about a third of young women who go on an oral contraceptive pill that contains estrogen get worse. So a third get better, a third have their migraine get worse, and about a third are pretty neutral in terms of headache. So it's important because to think about it and to be conscious of what's happening with your migraine. So sometimes people will notice they have bigger headaches. That may be the first time someone has migraine with aura. So that's a common thing to have it at that time. And if people are not being careful, what they may not realize is all of a sudden the headache's gradually getting worse and worse and worse. And Lee Kudrow, Dr. Lee Kudrow, who's the father of Lisa on Friends, he was is a very well-known headache specialist, and he described back in the 1970s that starting someone on the pill could serve as a way to transform the headache from episodic headache to chronic headache. In other words, going from fewer than 15 days to more than 15 days. So it's an important thing to watch. And if girls can't be, or young women can't be on oral contraceptive pills, then they need contraception. They may go to something like the Mirena, the Skyla, so they're different. And then some women just don't do very well on the pill. Other women actually have their migraine improve. And sometimes if they're just left with a placebo week of menstruation, they can drop the placebo week and take it continuously. Wow. So there are lots of different strategies, but it's important to really think about, is it safe? If you smoke and you have migraine with aura, you may not need to take the pill because it may increase your clotting risk. So again, if you have no history and you have your clotting enzymes are normal or your clotting factors are all normal, that may not be an issue for you. So it really takes, I think, a careful approach to it. And to make that determination. Pregnancy is another time. Pregnancy is a higher estrogen state. Many women get worse in the first trimester, better after that. Some women have no migraine through their entire pregnancy. If you have infrequent migraine or episodic migraine, you're much more likely to have none during pregnancy. Whereas if you're someone who has daily headache or you have chronic migraine, you're much more likely to have it not improve during the pregnancy.
And then the question is, what can you safely take?
What can you take?
Yeah,
that's right.
Absolutely.
And that's always
tough.
trickier.
Sure. Let's jump back to the phone lines. Lily is on the line. Lily, good evening to you.
Hi.
Go ahead with your question.
I had a question about, I don't know, I missed some of it. I don't know if you said anything about hereditary. My son started having migraines when he was 4 years old. He has now passed away, and his son is having migraines also. So I'm just wondering, did he pass it on down to him?
You have about a 50% chance of passing one of the migraine genes down if you have a parent. So your little grandson has about a 50%.
He's 18. He's 18 now.
Okay. Well, that seems little to me. Okay. I'm not a pediatric neurologist, but so your young man has about a 50% chance of having gotten the gene from his dad.
Okay. Okay.
If his mother has it, he has about a 75% chance of having migraine. So it's actually pretty common. And you know, sometimes the transmission occurs in different, you'll see it through male line, sometimes you see it through women. So sometimes I take care of whole generations of migraineurs, and I'll have some men, some women, and it's absolutely fascinating. Sometimes you'll see more of one pattern in men than in women. Sometimes the women have more aura, the men have less aura. Sometimes the men have more aura. Sometimes the men have only aura. And migraine's one of the, it's really a condition or a disorder that changes over one's lifetime, and it may change with hormonal status, it may change by decade. So it has it's much more interesting to study it than it is to have it. And although I do have migraine, but it's really important that, so it sounds like he's young. If he's athletic or enjoys outdoor activities, it's important to make sure that he's treated. It's also important to check things like to make sure his blood pressure is doing well, that he doesn't, that he's not smoking, all the kinds of things that grandmothers are always encouraging grandsons and sons. I'm sorry that he's lost his dad and you've lost your son. Migraine does not increase the risk of death. So migraine, though, is an aggravating, annoying, it can be a completely debilitating medical condition, though it has some increased risk of stroke. Again, higher in migraine with aura than migraine without, but it doesn't really convey an increased risk of death. So the important thing for your grandson is really to have, if it's frequent, to have his migraine evaluated if he develops it. But we'll cross our fingers that he is in the other 50%.
Yeah. Lily, thank you for your call tonight. And I think that you said, and the ladies in the back said this too, there's a gene. There's a gene that dictates whether you have migraines or not. Did you say this?
Yes, there are actually many genes.
Wow.
So there are 3 genes that have been well mapped for the rarest of the forms of migraine. These are called familial, meaning it has to be inherited. Familial hemiplegic, where there is weakness on one side of the body. So there are 3 genes for familial hemiplegic migraine, types 1, 2, and 3. The third one was actually mapped by Dr. Alfred George at Vanderbilt.
Oh,
so
wow.
yes, so we have a local, really a geneticist here who's mapped that. So these are genes that have specific defects in various things. The first one that was mapped is a defect in the PQ calcium channel in brain, and that defect leads to an excess amount of glutamate, the neurotransmitter that again produces an excitability at the level of the neuron. So that's how it was determined. So all the defects lead to something that increases excitability in the brain. That's why so many of the drugs we use to treat it reduce that excitability. So many of them are anti-epileptic agents.
When we come back, I want to talk about the drugs that are on the market now, what's coming, and some other treatments that are not drug related, if folks want to go down that route. All right,
Absolutely.
when we come back, more on migraines and headaches. Stay with us.